All right, well, good evening. I'd like to welcome everyone to tonight's Medical Student Interest Group webinar, where we'll be continuing the MSIG webinar series on textbook injuries, where each speaker tonight will share their expertise on a specific sport and identify the most common injury or injuries from that sport. My name is Kaylee Blevins, and I'll be the moderator for tonight's webinar. I'm a third-year medical student here at the University of Colorado. I grew up in Durango, Colorado, surrounded by mountain bikers and skiers and other outdoor sports, which has really informed my interest in going into sports medicine. And I'm hoping to either pursue a residency in PM&R or in pediatrics. And I'm very excited to introduce our speaker panel for tonight. First, we'll have Dr. Robyn, who will be making a presentation on figure skating, and then we'll have Dr. Dana Kotler on a presentation on cycling, and then we'll have Dr. Smuwara making a presentation on triathlons, and then Dr. Kotler will return again to do another presentation on Pilates. It's an honor to have these three AMSSM members serve on our panel, and after their presentations, I'll serve as a moderator for a Q&A with our speakers, so everyone can just enter their questions in the chat, and we'll read each question out for the Q&A segment. Now it's my pleasure to introduce our first speaker tonight, Dr. Robyn Knutson Bueling. Dr. Robyn has a clinical sports medicine practice in Minnesota, and her interests are in concussion, youth athletes, arthritis, and avoiding injections. She is a sideline junkie with team physician experience at all levels. She currently is a collegiate team physician. She is a physician for pro baseball and soccer, along with junior hockey and semi-pro rugby. But her favorite sports coverage is in the Olympic sports realm, and she has served as a volunteer team doc at the US OPC Training Center, along with being a longtime physician for the US figure skating team. So Dr. Robyn, you have the floor.
Hello, thank you for having me. Okay, I'm gonna try to share my screen. All right, so my name is Robyn Knutson Bueling. I'm a primary care sports medicine physician in Minnesota. And I've been doing this, I guess, getting close to 15 years now. And once it gets over 10 and you start doing math, then it gets embarrassing to figure out how many years you've been doing the same thing. So that's about how long I've been doing this. So they asked us to just give you just a little bit of background on how we got to where we are. I was a figure skater. I guess in theory, I was above average or somewhat decent at what it was that I did. Although not nearly as good as the athletes that I take care of. I played 4 high school sports, like lettered in 4 high school sports for a number of years, but probably was better at figure skating. And I was a musician and played a handful of instruments. And so I guess that sort of is what makes me a little bit different than maybe your average sports medicine doc. I coached a number of sports, including figure skating. I managed a swimming pool for a number of years. I worked at a health club. This was clearly, I was just sort of a sporty person. I went to medical school. I thought I was going to be a pediatrician, maybe a pediatric cardiologist was what I thought I was going to be. That is not at all what I turned out to be. I did family medicine residency here in Minnesota. I stayed involved in sports, but didn't have any, I don't know, thought about doing any sort of fellowship. I stayed involved in a high school training room. I worked the local marathon. I worked the giant soccer tournament, the USA Cup that comes here is the biggest youth soccer tournament that exists in the country. None of those really were part of in any sort of intentional pathway to fellowship. They just were something that I like to do. And so my faculty advisor basically was like, this is actually the thing that you're supposed to do. You shouldn't do anything else. You need to apply for fellowship. So I did. He was right. Thank goodness for smart people. So I did primary care sports medicine fellowship. I applied at a number of places, but we actually already owned a house here and I had 2 kids. I had one in medical school and one in residency. Woo! So we stayed here. I was lucky to have a director who had similar interests in some of the aesthetic performance kinds of sports that I did, but also had a very wide breadth of knowledge. And I mean, she was the football doctor too. And so that was really nice. And while I was a fellow, I applied and was accepted to be part of the international traveling team pool with US Figure Skating. So I've been doing that since fellowship. I stuck just a couple of photos in there of what it looks like to be an Olympic sport team physician. So this was actually being a medical director at an event we hosted here in the US. So bringing international athletes here in the US that happens to be in Salt Lake City. So just a little bit about figure skating. Not everybody wants to know everything there is to know about figure skating. I do, but not everybody else does. So a little bit to know if you happen to see one in your clinic of all of the other sort of regular folks. It is commonly an early specialization sport, whether you like it or not, it is. It is commonly an overuse, overtraining kind of a sport. It is not uncommon to see a kid in elementary school training 2 to 4 hours, 5 or 6 days a week. And so this takes a lot of work to figure out how to partner with an athlete and a parent and a coach and help make their training safer and effective, while not just simply saying, don't do that, and getting them to trust you to come back and see you again. It does require a lot of hypermobility. There is a lot of high impact. We have a couple of pictures there for you. There's a lot of hyperextension at the hips, the lumbar spine, the shoulders, and then there's a lot of high impact to the spine, the hips, and really everything in the legs. So that informs a lot of the kinds of injuries that we see in figure skating. There's not a ton of great data on figure skating injuries. There's some, there's not a ton. Actually, Ellen Gemiani from Boston has done a decent amount of the data collection on this. Most of the injuries, they sort of fall into 2 buckets, either the singles athletes or the not singles athletes. The singles athletes, both the men and the women, tend to have more overuse injuries. The athletes who skate non-singles, so pairs or ice dance or synchronized skating, which is like a team situation, they tend to be more likely to have an acute injury, to fall and break a bone, to have someone's blade cut them open, or something of that nature tends to be more likely to be seen in a team situation. Most common locations of injuries are in the lower extremities, the ankle, the knee, the back. Male pair skaters also have quite a high likelihood of shoulder injuries, because they're lifting people over their head and throwing people far into the distance. So then I tried to sort of break it down a little bit more into what kind of injury should we talk about here? Because that's like all of the things. So stress injuries are very common. Bone stress injuries are very common. And back pain is very common. So that picture is basically what I look at for anywhere from like 10 to 16 hours a day when I travel, which is a really cool view of skating. It's also cold, but it's lovely. I try really hard to not have to work and just get to enjoy it. So bone stress injuries. Bone stress injuries are overuse injuries, basically due to repetitive training of some sort of specific skill. Oftentimes this is a repetitive jump or a repetitive takeoff or a repetitive landing. Sometimes it's also a repetitive position. So a hyperextension of the spine is a pretty common one. Most of the time when I see these athletes, they have had this issue for quite some time before they come in to see us. They've been trying to manage it on their own. They've been stretching, they've been massaging, they've been taking over-the-counter medicines, they've been using ice. They maybe tried not doing a particular thing and doing something else to see if they could get it to go away. There is significant fear in this population and significant fear in their coaching staff of being removed from their sport, being just told they just can't skate. And so they seem to be very avoidant of seeing the doctor if they can at all help it. So whenever possible, we try to work pretty hard to do some relative rest, to find ways around taking athletes off the ice entirely, allowing them to do something other than that one particular offending injury. Common places for athletes, for figure skaters to get a bone stress injury, mostly in their lower extremities, tibia, fibula, metatarsal are pretty common and fairly low concern. Obviously the hips and the spine are bigger deals. So then, as an example, because I didn't want to go to, oh, sorry. We'll talk a little bit more about overuse of bone. So then we talk about with athletes with bone stress injuries in figure skating, how did they get it? And how can we help them get rid of that? In general, things that cause bone stress injuries in figure skaters, a lot of that is external load. It's oftentimes volume. It's how many hours a day are they training? How many times are they doing the same thing? How hard are they training? How old is their gear? Does it fit them correctly? There is a significant concern about internal load. What is their energy balance? Are they fueling correctly for the activity they're doing? And this is commonly a problem. Do they have the right muscle strength for what they're doing? Are they actually well-trained athletes, or are they just good figure skaters? Do they have stable hips? Do they have stable core? Personal characteristics, do they have funny shaped knees, hips, ankles to begin with? And then psychosocial issues. Are they sleeping well? Do they have outside stressors? How tired are they? How stressful is school? Hello. Okay. And then how do we intervene with this? We manage their external load. We can do a jump count, just like Little League does a pitch count. We can limit the hours of training. We can limit the intensity of training. We can limit the number of competitions or events. We can assist in planning in terms of when should you have busy season, when should you have not busy season. We can help stabilize surrounding structures. And then helping to find ways to manage the other factors, the nutrition, the mental health, sports psychology, understanding that sometimes your athlete's support structure is not as ideal as you want it to be. And that can include their parents and their coaches. And so sometimes you have to ask the question, like, should I let you, do you want to skate right now? Sometimes they don't. I have one right now that actually is super enjoying the fact that she's not allowed to skate, or that she told me that she doesn't want to be allowed to skate. So as an example of a bone stress injury in a figure skater, I see a decent number of stress fractures in the lumbar spine. Probably about 1 a month, specifically in a figure skater. So this is a stress injury to the vertebrae, most often to the pars interarticularis. So this is the little area in the back part of the lumbar vertebrae that is the most fragile part. You get a lot of stress on this when you do hyperextension motions. So we see this when they spin, we see this when they jump, we see this in lots of positions that figure skaters make. If it gets really bad, you'll get a crack and that vertebrae can slide forward, which is obviously more dangerous. This is caused by overuse, but also caused by genetics. Sometimes people are shaped in a way that the pars isn't fully hardened bone. And then they are more likely to have injuries to this area. So sort of the basics, because I know that nobody's going out and diagnosing and treating this tomorrow, but as a basic sort of diagnosis and treatment of a lumbar stress injury in a figure skater, usually what you'll see is that they have pain with extension or impact. So either they're doing a lot of spins in a position where they arch their back, or they're having a lot of pain when they're landing jumps. Oftentimes this will come on over months where they feel achy and sore. Sometimes they'll notice a very sharp increase with a particular event, like they had a fall in a funny position or that sort of thing. Traditionally, we're taught that there's a Scotty dog sign or a sort of a obvious line or mark on the x-ray. I find that maybe we see this in about half, maybe at the most on x-ray. You can get a CT scan, but MRI is really the gold standard of imaging for this. And so we do mostly MRIs at this point. Bracing for lumbar stress injuries is controversial at this point. The most recent data shows that 83% of lumbar stress injuries will improve whether or not you put a hard or a soft brace on them. And then treatment is basically going to be a short period of rest, then some relative rest. Maybe they can go back and they can skate, but they can't jump or spin, and then they can spin, and then they can jump. And this takes a period of a few months with some gradual increase over that period of time. Again, that fear of not being able to do anything is very strong in this population. So if you can find a way to be able to do anything, that's a big deal. Physical therapy is super important. A lot of these athletes, because they're early specialization athletes, aren't great athletes. They're just great figure skaters. So physical therapy can be super helpful for stabilization and mobility of specific areas around it. I generally tell athletes this is probably a 3-month process. If we get to 6 months and they're not back, then we're talking about seeing a surgeon. This is my last slide. The truth is we don't have a ton of research on early specialization sports. They have a lot of pressure to feel like they're meeting the same milestones as everybody else. But we still need to figure out a way to keep them safe. Bone stress injuries are super common in early specialization sports. So we need to look at periods of growth and try to figure out when we can alter their training to try to keep them safe. I try to advocate for at least 1 day off a week, at least 2 weeks off a year. Yes, for real, 2 weeks off a year. If I can get a figure skater to take 2 weeks off a year, I have won the prize. If I can get 4, I mean, that's like a miracle. And then I try to get kids to take up one other activity, take swimming lessons, play tennis, do yoga. That's it. That's Junior Worlds. And I don't know, that's what an ice skating rink looks like in, where did I go? Tallinn, Estonia. Sometimes I don't remember where I was. I'll go back to that.
Great. Well, thanks so much, Dr. Robyn, and we'll have some time at the end for any figure skating related questions. So now it's my pleasure to introduce our second speaker, especially as a cyclist and the sister of a professional cyclist. Dr. Kotler is a physiatrist and sports med physician and an assistant professor of PM&R at Harvard Medical School, formerly a dancer and then a Pilates instructor. She did her medical training at the Albert Einstein College of Medicine, her PM&R residency at the Shirley Ryan Ability Lab at Northwestern, and then her sports medicine fellowship at Spaulding Rehab and Harvard Medical School in Boston. Like Cambridge. Dr. Kotler has lectured widely on both Pilates method and core training, as well as back pain and cycling related injuries. She founded the Spaulding Cycling Medicine Program nearly 10 years ago, which uses a collaborative evaluation approach to diagnose and manage medical problems in cyclists and has seen over 350 cyclists since its inception. She's authored papers on overuse injury, as well as traumatic brain injury in cycling and training and injury considerations of women cyclists. When she's not seeing patients, you can find her riding her bike outside or on Zwift and taking care of her 2 cats, plus a couple of foster cats. And with that, Dr. Kotler, I'll let you share your screen.
Thank you so much for the introduction. Hopefully this is the right one because we got 50% chance of being right. Okay, so this is the cycling talk. Excellent. Thank you for having me to talk about bikes, one of my favorite topics. And with that, let's get started. Nothing to disclose. No cycling companies pay me to talk about this stuff. So in terms of how I got involved in cycling medicine, my mom was a cyclist, and she, just for, a recreational cyclist, but like in the 70s and 80s, that was a little bit weird. Like there weren't that many women cyclists, and she would like ride with the guys and ride like a guy's bike because like they didn't make any specific like, stuff for like women or smaller riders. And I thought it was weird, but then some of my friends started riding bikes. And so I started riding bikes. And I started riding with my mom. She taught me about bikes. And then like everybody about like, 20 years ago in the early 2000s, I had to try like a triathlon. So everybody did a triathlon on the weekend. So I did a triathlon or 2 or a couple. When I moved to Chicago for residency, riding bikes is a good way to make friends. So I met a lot of people through bikes. And same thing happened when I moved to Boston for fellowship. It's a good way to meet people and make friends. I did some bike races in that time. I wasn't very good at it, so I don't really do that many bike races anymore. I started the Spalding Cycling Medicine program in 2015. We won an award down at the bottom right. You can see that's us with some awards. I started writing and lecturing about cycling medicine because it was something that I was interested in. And it was a way to find my shtick, as my department chair said. He's like, you got to find your shtick. What are you good at? What do you like doing? What do you like seeing? So cycling medicine was mine. I became part of a program called the Anne Klevansky Scholars program in 2023. And with that, I gave a lot of talks about cycling medicine, including out at Mayo and the USOPC. And it was really exciting, and it gave me a chance to really work on a lot of the lectures, and you'll hear some of that stuff today. And I'm still writing, and if you're on Zwift or Strava, you can find me there. So I think before we even get into the injuries, I am going to talk a little bit about the biomechanics of cycling. So how do we make a bike go forward? So bike is a pretty simple construction, right? So in order to make a bike go forward, you apply force to the pedal with your foot, unless you're riding a hand cycle, but we'll talk mostly about regular bicycles. But with your foot, you apply force to the pedal. That's this thing here, right? It's attached to what's called the crank. That's this arm here. It connects the force that you're going to put down to this chain ring, which is then going to pull on the chain, and it's going to turn your back wheel, and that's going to make you go forward. So what you're putting down is force, but it's because it's creating an arc, it's actually torque. So the force times the length of the crank is going to give you the torque. And then when you add a time factor in, you get power, which is the metric that we pretty much talk about universally in cycling. So what that is basically how much force you're putting into the pedals and thereby into the drivetrain of your bike, and how quickly you're doing that. So you can generate a lot of power by putting down a lot of force, or you can generate a lot of power by putting down a little bit less force, but putting it down quickly and repetitively, very fast. And so we think of that as like spinning. So you're just like spinning your legs really, really quickly, and that's going to make you go forward quickly. Or you can put a lot of force down and kind of grind away, and we call that mashing. So two different ways to pedal your bike. So kind of like in running, you can take big steps or you can take a lot of steps. So it's sort of the same thing. But because we keep turning our legs over and over again, cycling is very, very repetitive, and you're engaging in sort of millions of pedal strokes over the course of a ride or a weekend of riding or a summer of riding or a whole season of riding. And so small deviations in the mechanics of your pedal stroke, if your knees kind of going in or out, or your lower back is doing something funny, will really add up over time. And so that's why overuse and mechanical injuries really predominate within recreational cyclists and triathletes. We're talking not so much about people in races who are doing really risky things, but people who are just out riding their bike a lot. So like I said, the pedal stroke's very repetitive. So you're going anywhere from 60 RPMs at the absolute low end, that's really slow, up to like a really quick, like 120 RPMs for the duration of a ride, usually somewhere in the middle. Cycling is also just really time consuming. You can go out and ride your bike for a couple hours at a time. I think most of us probably don't go out and run for like 3 or 4 hours, but someone might go out and ride for like a couple hours, go get lunch somewhere, go get a cup of coffee, and take a nice scenic ride back. And also you have to factor in, like other sports, what your technique and what your equipment setup is, and that may be often related to injury. The other thing about cycling is that it's primarily occurring in what we think of as the sagittal plane, so front and back. Most of your motion is front and back. You're not doing a lot of side to side, lateral motion, like tennis or soccer might have. It's also a non-weight bearing sport, and because of that, it's very forgiving. So you can ride with some pretty lousy mechanics. You can get away with a lot for a long time before you develop issues. And so by the time we start to see these issues in clinic, they've often been there for some time, and it's, people say, well, it just sort of started, but then I fixed whatever, I changed my saddle back or I changed my shoes back and it didn't go away, because probably this has been brewing over time. So some of the more common areas, a lot of lower body issues, but also like the neck, depending on the position, the wrists, the forearms, etc. So the most common injury that I'm going to talk about today is pain in the front of your knee, so anterior knee pain. And the thing about the knee and the bike is that your knee is often the victim of a problem somewhere else. So either your hip is doing something weird or your foot is doing something weird, and that's throwing your knee into an odd mechanical sort of disadvantage. So anterior knee pain, or what we call patellofemoral pain, is usually a result of increased pressure on the front structures of your knee, right? So the patellar tendon and the patella pushing backwards against the femur behind it. So you have these increased contact pressures and load through the patellar tendon. And there's kind of a few things that can contribute to that on the bike. So one is the fit of the bike. So if you're, and I'll talk a little bit about sort of good fit in a second, but essentially if your saddle is too low or too far forward, what that's going to do is shove your knee forward. And so it's going to make you have more knee bend, and it's going to put your knee ahead of the ball of your foot. And that's almost like doing a squat with really poor form where your knees are shooting out in front of your toes. So not ideal for the knees, kind of lousy mechanics. The other thing is, what kind of riding are you doing? So are you putting in really hard, grindy efforts up a lot of hills, or really like what we call the low cadence mashing type of efforts? A lot of sprinting, all of those can factor into someone having pain in the front of the knee. Do you tend to ride with a really slow cadence? And then some of the other structural issues that have been known to be associated with patellofemoral pain or anterior knee pain. So weakness around the hip area, pronation of the foot, or just like if you have some early arthritis in the knee, some degenerative change in the knee, that can certainly be associated with it. So when we see people in clinic, we look at a lot of different things besides just the area that hurts, of course. So we're going to look at what their spine and hip range of motion is, because if any of that stuff's limited, that's going to affect what the knee does on the bike. We look at hip flexor tightness, IT band tightness. We look at the strength of the hip abductors, especially the gluteus medius. We look at their foot structure. Does their foot tend to be really collapsy? What does their shoe pattern look like? And sort of what their neck and shoulder range of motion looks like. So appropriate position on the bike should be a pretty easy to maintain position. You're on a regular kind of road or mountain bike. You're essentially upright with a bit of forward tilt, and it should be kind of a very neutral position. And you can imagine, like in a lot of other sports, there's this sort of neutral ready position, whether it's like my friend Amy here lifting this barbell, or whether it's like a tennis player. You're just like slightly pitched forward, knees are bent, spine is really neutral, and you're like ready for action. So that's kind of what the position on the bike should look like. It shouldn't take a whole lot of work to maintain. Your bike should just kind of put you there, and it should be pretty comfortable, ideally. You want your weight right over your pelvis on your ischial tuberosities and distributed between your butt and your hands, with a little bit more on the back end of the bike. So about 60-40 saddle to hands. Your arms should be, active, because you're working a little bit to hold yourself up, but kind of minimal tension. You want your knee angle when the knee is more or less at the bottom, when the foot is at the bottom of the pedal stroke, to be somewhere around 30, maybe 35 degrees, and the arms to body angle is about 90 degrees. You want easy access to your brakes and your shifters up on the handlebars for safety, of course. Oops. There we go. Okay, so we talk about the contact points of the bicycle. So the first one is the saddle. And so we can move the saddle up and down. And when you move it up, it's sort of also moving backwards, just because this isn't traveling fully vertically. It's traveling kind of up into the back. You can move it forward and backwards, and that's going to adjust the position of the rider on the bike in terms of what their hips are doing, what their knees are doing, and even down at the lower end, like what the ankles are doing. You can tilt the saddle, so a little bit nose down. You pretty much never want it to be nose up, but sort of level to very slightly nose down. You can also have different saddles that are different shapes. So they can be a bit wider, a bit narrower. They can be a little more sort of swoopy up at the back. They can be a little bit more domed with sort of a drop off. And these all look kind of the same, but they are a little bit different. The other thing is what you're wearing on yourself. So are you wearing a padded set of cycling shorts? Do you have any lubrication? We often use lubrication to prevent excess friction and skin breakdown. So that's the first contact point. Second contact point is the feet at the pedals. And so typically for a cyclist that has been doing this for a while, they can use a clipless pedal system. Some people prefer to use flat pedals, which is fine. But a clipless pedal system is pretty nice because it allows for consistency. It means your foot is always positioned the same way on the pedal. It's not going to slide forward, back, rotate in or out. And it releases just kind of like a ski binding would release, where you just kind of, as soon as it gets any torque to the side, it'll let your foot out, although some are tighter than others. This allows for efficient power transfer through the crank, as we talked about, and the crank length. So the length of this part of the bike is going to affect the angles of your joints. So the longer the crank, the bigger the circle that your foot is going to make. And therefore, the more your knee is going to bend and the more your hip is going to bend. So there is some flexibility in terms of what length crank would work for certain individuals. If they have like restriction in their hips, they don't want a crank that's going to put their knee way up into their chest while they're pedaling. You might go for something a bit shorter. The foot's making a smaller circle, the knee's not flexing as much, and the hip is not flexing as much. In addition, you can adjust the cleats where you can adjust the cleats on your shoe to move your feet in or out, depending on the width of your pelvis and how wide your feet need to be. And there's some modifications you can make within the shoe and even to the external part of the shoe to help get your foot in an appropriate position, because that's going to be important all the way up the chain. If your foot is starting to collapse inward, your knee is probably going to follow it. Third contact point is the handlebars. And so that's basically the front end of the bike. So you have your stem length and rise, which is basically going to put your handlebars sort of higher or further forward. And this is going to affect what's called your reach. So how far ahead your hands are relative to your torso. And that will also affect the angle of your torso. If you're having to reach really far forward, your torso will probably be a little bit lower and your hip angle is going to be a little bit increased. There are many different shapes of handlebars, drop bars, like on a road bike, flat bars, aero bars, like on a triathlon bike, which you'll hear about later. And we measured the width of those bars from acromion to acromion. And then that you can make some modifications as far as the rotation and the different types of componentry that you can have as far as your brakes and your shifters. So when we see a patient in clinic, we look at them on the bike and we basically look at them from two directions. First, we typically look at them from the side. So we're looking at them in the sagittal plane. And the big thing, one of the first things we look at is what is their knee angle? So as their foot gets towards the bottom of the pedal stroke, how bent is their knee? And what we want to see is, again, that sort of 30 to 35 degrees. Technically, we could go even as low as 25 degrees, but most people's hamstrings are pretty tight. And so if their knee is getting all the way to as straight as about 25 degrees from full extension, that might be kind of yanking on their hamstrings. You might see them point their toes a little bit. So you can see this guy's got like a slight knee bend, but this person has almost a straight knee. So this saddle is way too high and this saddle is a bit more appropriate. But if their knee is really, really bent, that's going to be an indication the saddle's too low. You can also look at their spine position. So are they kind of round through their lower back or are they more kind of neutral? Like this person had a restricted hip and was really tucking his pelvis under, and that was causing his back to round quite a lot because he had this hip problem. Again, looking at that reach, looking at what the neck is doing, looking at the elbows being slightly soft. And we ask a lot of questions about what people are feeling while they're on the bike. So we ask a lot about the saddle, especially because many things that we'll see, we can often chalk up to a problem with the saddle. So if they're kind of sliding forward, if they're fidgeting around, if they've got some pressure, that's going to make them tighten up in their neck. Their shoulders going to make them throw more weight into their hands in an effort to sort of unweight their butt a little bit. We then look at them from the front, and the front is a really good place to see what the knee is doing. So if the knee is kind of wobbling from side to side, you can see, we can set up a little laser level, just like a Home Depot laser level. And that'll show us if the knee is sort of starting to drive in, if it's starting to kick out at the very top. This is on the right is a really good example of a knee that goes way out to the sides at the top of the pedal stroke because this guy doesn't have a lot of hip flexibility, so it forces his knee outwards. And these motions of the knees can be indications of some reduced hip control, some hip restriction of the range of motion, or some like collapse of the foot, or even just some arthritis of the knee. So we also look from the back because that helps us see if they're sitting centered on the saddle. So when we're treating something like anterior knee pain, you want to fix the bike and you also want to treat the rider. So in terms of the bike fit accommodations, as we said, you might want to move the saddle up a little bit and or move it posteriorly. You might want to check the level of it to make sure they're nice and supported. You might want to think about the crank length. Do they need shorter cranks to reduce some of the tension across the knee and the degree of knee flexion? And that's a perfectly fine thing to do. It's actually a trend in cycling. A lot of people are doing it because it does take the pressure off of the joints and doesn't sacrifice any of the average power, which is great. We might look at the geometry of the frame if they're on a bike that kind of puts them into not an ideal position. And certainly look at what the pedals are doing. Do they have enough float or motion at the pedal? You also want to treat the rider. So if someone's got patellofemoral, anterior knee pain, want to make sure that their hip strength is optimized, that their quads are not super, super tight, which is just going to exacerbate things. Make sure they have good quad hamstring balance. And then also look at sort of what their feet are doing. If they've got tendinopathy, so chronic wear and tear on the patellar tendon, there's treatments for that, different types of injections, shockwave therapy. If they have cartilage problems behind the kneecap, you might consider a specific treatment for that as well, whether it be injections or just kind of offloading it with physical therapy. And bike fit is dynamic, so we may have to go back and make other adjustments to the bike as they're starting to get better. So in general, like when we see cyclists in clinic, we want to understand the medical problem, the underlying medical issues, but also the biomechanics of cycling, which is what I've tried to get across to you guys today. Keep in mind that that repetitive motion in the sagittal plane is the thing that contributes to the overuse injury, and as well as imbalances in sort of the abductors, which we really need for prevention, and multidisciplinary treatment. So treating the athlete, but also adjusting their equipment, working between physician, physical therapist, bike fitter, coaches, and athletes. I wrote this paper on prevention and rehab of cycling injury that came out in like 2016. So it's a pretty good one if you like cycling and you want a reference to take a look at that. And those are my cats.
All right. Thanks so much, Dr. Kotler. And next we will move on to Dr. Smurawa. So just to introduce Dr. Smurawa, he is a sports medicine physician and the director of sports med at Children's Health Andrews Institute in Plano, Texas. He also serves as the medical director for the Texas Association of Private and Parochial Schools organization and oversees the medical care of these championship events. He's the team physician for the Prestonwood Christian Academy in Plano, Texas. He graduated from the University of Wisconsin and is a graduate of the University of Texas Health Science Center Medical School. He completed his residency at the University of Wisconsin and then completed a fellowship in sports medicine at the Akron School Children's Hospital in Sports Medicine Center in 1995. He's certified by the American Board of Pediatrics in both peds and sports medicine. And since 1994, he has been on the medical staff for the USA Triathlon team and travels as a team physician to World Championship team events. He also serves as the USA Triathlon Multi-Sport Medical Conference Committee member. He's certified by USA Triathlon, Track and Field, and USA Cycling as a multi-sport coach and coaches elite and novice runners, triathletes, and other multi-sport athletes. He's a Sirota International Cycling Institute certified bike fit specialist and is a competitive runner and triathlete himself, running multiple marathons, triathlons, and 6 Ironman triathlons. He has a special interest in youth ballet and dance medicine as well, and is an active member of the American College of Pediatricians, the American Medical Society for Sports Medicine, Pediatric Research in Sports Medicine, and the North American Society for Pediatric Exercise Medicine. And with that very impressive introduction, I will hand it over to Dr. Smurawa.
All right. So I am going to talk about triathlon, which actually is 3 sports. So I'll try to go over all 3 of them, except we went through cycling before, so I don't have to say much about that. Just a little about myself. Again, I started my involvement in triathlon. I started as a long distance runner in medical school, did multiple races and marathons, including the Boston Marathon several times, and then realized as a physician to be that if I keep running this many miles, then I might end up with injuries. So I added cycling for cross training, and that progressed to racing duathlons and triathlons, eventually competing in Ironman triathlons. Get this out of the way here. And I also, as mentioned, I joined the USA Triathlon medical staff as a team physician, traveling to world championships throughout the world over the past several years. Also, I'm certified as a coach in triathlon, track and field, USA Cycling, and also a certified sort of bike fitter. When we talk about triathlon, the biomechanics is basically a set of 3 sports. In swimming, we're basically talking about the front crawl stroke. In bike and biomechanics, we're talking about triathlon specific bike fit. And in running, we're talking more about an efficient running form. Oops. So when we talk about efficient swimming, there are different things we can look at when we talk about the phases of the swim stroke. The first phase is the catch phase, and that's when you reach forward, your hand enters, and you start to catch the water. Then the second phase is we call the pull phase. That's when the most of the force is generated and moving the body forward. And the third phase is the push or finish phase, is where you finish off pushing your body forward through the water. And then the last phase, phase 4, is the recovery phase. And that's where your arm comes out of the water and swings across, and it comes back to start to cycle over. And just remember, as this one arm is doing it, the other arm is also doing the same phase of the stroke, but in a different rotation, because you're going from left to right and right to left. So when we talk about open water swimming stroke mechanics, it's a little bit different than swimming in the pool. And the reason is that when you're in a pool, you have a lane line to keep you going straight. In open water, you have to rely upon good stroke mechanics, a good swim sighting to keep you in the right direction. So the key components of an efficient open water swim stroke, we look at symmetrical, synchronized body roll. That means that you're rotating to the left and to the right, and it's synchronized with your upper and lower body. So you want your hips and pelvis to be rotating concurrently and synchronized with your arms and shoulder. And we talked about the phases of the stroke. The beginning phase, the forward arm entry. You want to make sure the arm is entering in a forward position, that you have a powerful pull through and have a high elbow recovery. And that's more important of the elbow recovery because when you're in open water, you may be swimming in very rough water where there's waves and there's a lot of turn around you. So you want to make sure that your arm is high and recovering well, not your hands not catching on the water as you go through the recovery phase. Bilateral breathing is important. Most so for bilateral breathing helps with maintaining an equal roll to the left and to the right. Now, obviously, when you're swimming in a triathlon, based upon where the other swimmers are, where the waves are coming from, you may have to swim on one side because you want to avoid getting a mouthful of water every time you breathe, but you may never know if that's the left side or right side. So you want to be able to have the opportunity to bilateral breathe as you're swimming. A streamlined body is important. You want to have a streamlined body because that'll prevent you from called S-shaping or serpentining through the water, and that will help you have a better swim direction. If you're not looking where you're going and you swim, you may be swimming double the distance because of the curving that you're doing swimming. So you want to be able to swim in a straight line, going from point to point. And so that is important to know about what's called open water sighting and straight line swimming. So you want to be able to look forward and sight where you're swimming, and then continue going that straight line. And then when you sight again, that you continue to maintain that stride. That's very important in open water swimming and a triathlon, so that you stay on course. You also have to take in consideration any current that may be involved that might shift you from one side to the other. So some of the common swim biomechanical errors, one is called an S-shaped body line. That's where you are asynchronous between your shoulders and your hips. And then what ends up happening is that your body is actually twisting, almost like snake-like movement. And so you end up going through the water like what we typically see a snake go through the water. So their body be twisting and turning in more of a serpentine line of swimming versus a straight line swimming. And then the other common error is an asymmetrical, unsynchronized body roll. And so that means that asymmetrical means your left and right side are not doing the same. So you might be reaching, your reach might be shorter on one side. Your body roll may be less on your breathing, on your non-breathing side and your breathing side. And then your hips and your legs may not be synchronized with your upper body, and therefore you're twisting, and that may change your line of swimming and your line of sight. The other thing that is with the swim mechanics that can affect your swimming efficiency is arm crossover. So this is if your arm is crossing over the center of your midline, and that will create increased forces and increased change in your swimming mechanics. Poor arm pull. If you're not pulling through, then you're just spinning in the water and you're not getting the amount of distance you want per stroke. And then low elbow recovery. As I mentioned, low elbow recovery can cause you to drag your hand in the water, which might catch the waves around you when you're swimming, and that can throw you off. And then you may end up having a shortened elbow or hand reach, and your catch phase may be shortened because of that. Unilateral breathing, if you're breathing to one side, that means you're probably going to roll more to the breathing side. It also may affect your ability to sight, and you might start to go off course. And then again, insufficient open water sighting. If you're not sighting appropriately, you may get offline. If you're in more calm water, you don't have to sight as often, but when you're in more turbulent water, more wavy water, you may have to sight more frequently so that you're able to see and maintain your proper direction and which directions you're going in the open water. So a brief one slide about proper triathlon bike fit. Pretty much the same things come into effect with the regular bike fitting in a road bike. The thing that the components of an efficient triathlon bike fit is, one is the seat position. So you want to look at the seat height, the fore and aft position, and the seat tilt. And then in triathlon bike, basically you have the aero bars. So you're resting your arms on the aero bars. So the bike seat and aero bar weight distribution is the same as you would want it to be with a road bike. It's 60-40. And the important thing is that when you're fitting the bike, that the aero bars are adjusted so that they're in the right position and have the right weight distribution, and that they're more efficient in bike fitting. And it's also important too, as far as the width of the aero bars in your arms, because that can affect your aerodynamics, but also can affect your breathing. Too tight, a tight arms together will be more aerodynamic, but that can affect your chest opening. It could slow down and impair your breathing. You could increase the opening of your arms, the separation of your arms, to improve airway, but you want to find that we call that sweet spot, where you're getting the aerodynamic efficiency of your arms together, but not impairing the openness and the breathing in your chest as you are cycling. When we talk about running, so efficient running form biomechanics is important. So running posture, form, and biomechanics is very important for a running form, especially in a triathlon. So in a triathlon, running is the third leg of the race. So you have gone from swimming in water, where you're in a horizontal position and really not using your legs. Then you're going to the bike, where you're using more of a quadricep dominant type of position. Your hip flexors are in a more hip flex position. And so that when you get off the bike, especially after doing a long distance triathlon, you may have been on the bike for several hours, and now you have to adjust your body to running more efficiently in a better running form. So it's very important that you understand your running form, body posture, biomechanics, so that when you jump off the bike onto the running form, into your running leg, you are maintaining a proper running form. Because if you're doing a long distance run in a triathlon, if you have proper form and you're fatigued from the bike, it's going to catch up to you quickly, and you're going to fatigue very fast. But if you can efficiently switch over to a more efficient form, even if it takes several hundred yards to adjust to it, you'll in the long run have a better, more efficient running, utilize less energy, and be able to finish the race without any significant fatigue or problems with muscles and cramping and joints being affected. So a good running posture, form, and biomechanics. The key thing is, as everyone will tell you in any sport, to have a neutral pelvis with a strong core. That is where you'll be able to maintain a good body posture. Midfoot strike is the most efficient strike, so that you're hitting with your foot and you're accelerating. You're not braking with a overstriding or heel strike. You want to have the center of gravity over your hips and your legs. So you want to maintain the efficiency. This is more of a running efficiency. By having your center of gravity, your hips and the leg, you're going to be able to transition from left to right and moving forward. And so you want to have your feet underneath your hips. You do want to avoid overstriding. You want to have a slight forward body lean, but that's without pelvic tilting. So you want to maintain a neutral pelvis and slightly lean forward. And you should have a forward arm swing. You should have it so your momentum, your arm swing with your elbows at 90 degrees, and your forward movement and synchronize with your opposite leg will help you to have a better forward movement, and it'll help you with your with accelerating forward. And when we talk about running, we talk about lift legs, not push off. So you don't want to be pushing yourself forward. You want to be lifting your legs up forward. And the concept is we're falling forward fast. So you think if you're falling forward and you're picking your legs up rather than pushing yourself forward, you'll have a more efficient running form. And then we talk about higher cadence. That's your foot strikes per minute. With a overstriding, you're going to have a slower cadence. So if you pick up your cadence, that will actually improve your running efficiency, will improve your stride efficiency, and you'll have less of that slowing down or braking forces from a heel strike. Some of the running form areas we talked about are heel strike and overstride gait, anterior pelvic tilt, upper arm crossover swing, excessive shoulder and hip rotation, and low cadence. And the way to correct it is have more of a midfoot strike, having a shorter stride with your center of gravity over your hips, a more neutral pelvis, upper arm forward swing, lifting your knees instead of pushing off. And one of the drills that we use is using a metronome cadence drill. So what you do is you have the metronome on your phone connected to your AirPods or your earbuds, and then you measure your cadence per minute. And then if you're measuring, basically I say do one leg, not both. So if you're at 80, your cadence is 80, then increase the metronome to 85, and then that forces you to increase your stride frequency, which oftentimes will force you to shorten your stride, and then it will force you to have a more efficient stride, and you keep doing that. The other concept I do is think about if you're running on ice. If you had to run on ice, if you're overstriding, you're going to be slipping and sliding. So typically when you're going to run across ice, you're going to shorten your stride and quicken your stride. So the most common swimming, I'm going to talk about the most common swimming injury that we see in triathlon is probably one of the most common swimming injuries, and that's swimmer's shoulder, or we call it anterior shoulder impingement. And what this is that the shoulder pinches underneath in the subacromial area in the anterior shoulder joint, which will cause basically inflammation of the subacromial bursa, and also it will pinch the anterior tendons and muscles of the shoulder joint. So what we typically will find in exam is they'll have a positive Hawkins test for impingement. They'll probably have a positive apprehension test and a positive Sulca sign if they have multidirectional instability as part of it. Oftentimes in female swimmers, they are very flexible and they have very loose and joints, and they will have more of an unstable shoulder. A positive load and shift test will also be positive for a anterior impingement. Empty can test will show if there's any associated supraspinatus tendonitis and weakness. They'll have a painful arc from 60 to 120 degrees. And probably the most important thing that I'll see is swimmers that are pretty much doing freestyle will have tight internal rotators and weak scapular stabilizers, and you'll be presented with more of those rounded shoulders when the square shoulders. Some of the causes in swimmers are if they have arm crossover during the hand entry catch phase, if they have asymmetric unsynchronized body roll, unilateral breathing will create more of an impingement, if they have tight internal rotators and weak scapular stabilizers, and then if they have an increased body crossover during the pull phase, that's underneath that they're crossing their body too far, and that will put more of an anterior impingement on their shoulder joint. And the way we correct it is first of all, correct any swim biomechanics, learn how to bilateral breathe, focus on core and pelvis strengthening, anterior shoulder stretching, scapular stabilization strengthening. And I tell people that when you're swimming, to try to increase the amount of backstroke you're doing in training in the pool, and that will help with those scapular stabilization strengthening exercises. Here's just a couple of exercises that hopefully will work here. So for stretching the front, doing a doorway stretch is probably the best thing. You can do this in a doorway. I tell people when you're in the shower, that's the best time to do it. You can do it in the shower in a doorway. So you're basically trying to stretch out those anterior shoulder muscles. So you reach forward and stretch. The other strengthening exercises, one is we talked about is the external rotation band with the shoulders. You're just basically with bands, you're externally rotating your shoulder out, and you're strengthening those shoulder muscles that are very helpful in having a powerful swim stroke. The other drill is performing are the seated rows. You can use a machine or you can use a TheraBand, a TheraTube. You're really focusing on stabilizing the scapular stabilizers and strengthening those muscles. And then lastly is I like doing the quadruped exercise. Some people don't like this because it requires balance, but this really evens out your stroke from left to right when you're able to do this. And it's a very, very efficient and drill that will help develop those strengths. Okay, that's all I have. Thank you very much for allowing me to present on triathlon.
Awesome. Thank you so much. All right, so we're going to welcome Dr. Kotler back for her second presentation on Pilates. So I'll hand the mic back over to her.
All right. Get these slides up. And share. Okay. So switching gears, you know, Pilates is it's a method of exercise more so than it is a sport. And it's actually kind of hard to come up with a lot of injuries related to Pilates. But for a little bit of background, how did I get involved in Pilates? So I got certified in Pilates in 2002. So I probably was a Pilates instructor before some of the med students may have been alive. Basically, I graduated from college where I was a dancer and I needed a job, and it seemed like a decent way to make a living and a good way to stay in shape at the same time. So I was certified at Power Pilates in New York City in 2002. And one of my mentors was Bob Leekins, who passed away a couple of years ago, but I'll show some pictures of him. And he trained in the line of classical Pilates. So in working with clients to try and get them stronger and more fit and more stable and accommodating some of the injuries that they were dealing with, I got really interested in rehab in general. And that's what ultimately, along with getting hurt a lot myself, led me to pursue my career in medicine, and specifically PM&R, and specifically in sports medicine. You know, that led me to an interest in biomechanics, especially of the sort of core spine and hip connection. When I was a resident, I actually created several workshops that were at the American Academy of PM&R from 2013 to 2015 with some of my esteemed colleagues from Northwestern, from RIC, Shirley Ryan. This is one of them, where I had a bunch of doctors and I was standing in the front of the room teaching them Pilates, and it was great. So Pilates is named after a person. So his name is Joseph Pilates. He was born in 1883 and he died in 1967. It's pronounced Pilates, not Pilates. It's a name of Greek origin. He is a German gentleman. These are some photos that I'm probably not allowed to use, but are from the Pilates archives. And you can certainly find them online. But this is Pilates at 57, and here he is. And him and his six-pack at the ripe old age of 82. And this is the original Pilates studio in New York City. There are many stories, many of which are probably myths, none of which are particularly well documented about Joseph Pilates' youth, including having a bunch of illnesses as a child. So a lot of stories about how he ended up devoting himself to improving his physical strength based on some of his own issues with his health. His theory was that bad posture and inefficient breathing lay at the roots of poor health, and he developed his method, which he did not call the Pilates method. We call it the Pilates method, but he called it contrology, or the study of control, in the early part of the 20th century. He was actually interned at camps during World War II in Lancaster Castle in England and on the Isle of Man. And during that time, it's said that he volunteered in the infirmary at the camps. And at that point, he developed the exercises that would become the Pilates method. And some of the original equipment basically looked like a hospital bed with some bed springs attached to it. And with those springs, you could do exercises so that you could even start to move earlier in the rehab process using the resistance of the springs, even while you were, immobile and lying in bed. He then came to the US in 1925 and founded a studio in New York City. And Pilates during the early part of the 20th century was very exclusive, very costly. He was hired to teach dancers at the Jacob's Pillow Dance Festival here in Massachusetts, out in Western Mass. He wrote a couple of books called Return to Life and Your Health, which are interesting reads. And then Pilates got really popular in like the 1990s. And so when I made this talk, there were hundreds of Pilates studios across the US. Now there are about 40,000 Pilates studios across the US. And it has just really exploded in popularity. And there are a lot of teacher training programs. Originally, there was just one. It was the one that he started. And then a lot of the disciples of Pilates went out and started their own teacher training programs. So just as a side note about the lineage of Pilates, so this is Joseph Pilates. He trained a dancer named Romana Kryzanowska, who then took over his studio. She trained a guy named Bob Leekins and Phoebe Cushman. And I studied with Bob Leekins. So very much right within the original classical Pilates lineage. So I'll talk a little bit about the structure of the Pilates method, because if you just go take like kind of a Pilates class at your gym, you'll probably have really sore abs and you'll get a nice workout, but you may not get the full breadth of the Pilates method. So the mat exercises, basically a series of exercises lying on a mat on the floor, are kind of the foundation of the methods. They are sort of the gold standard. They're all of the original exercises. With variations. Then there was equipment that was developed, and Joseph Pilates developed the equipment himself. He built it and he patented it himself. And it uses spring resistance to facilitate core engagement. So the springs give you something to push against to then activate in opposition to, or they help you do things. So you're often working with the springs to do things that either are not possible or just really, really difficult to do without any assistance on the mat. So this is the reformer. It's one of the pieces of Pilates equipment that you might see in a studio, or these days they make versions of it that people have at home. So it's basically a frame, usually made of wood or metal, and it's got this, what we call the carriage, which rolls on wheels up and down these tracks, and you can pull it with straps, which will the pulleys will cause it to move. And it's attached right here by these springs, and you have a number of different springs to get different levels of spring resistance. And so typically, pushing the carriage out is not very hard because the springs aren't that heavy if you're only using one or two, but the work is on the coming back in. So you can see in this exercise that if you didn't have springs to help you, you'd have to do a whole lot of work with like your lats and your serratus to bring yourself back in. So often you're working with the springs so that you can maintain appropriate form, and the springs can help you do the exercise. The chair is another piece of Pilates equipment, which is kind of the same thing. You have this moving pedal, but this time it's vertically oriented. And so this pedal is spring loaded. So pushing down the pedal, again, not that hard, but the work is often in bringing it up, and the springs are helping you do it. So this is an exercise called pumping or footwork. And you can see that if you didn't have the pedal there, pulling your knees up into your chest just against gravity would be really, really difficult, especially if you're trying to maintain good, nice, lifted posture. There's a few other pieces of equipment. This is called the Cadillac, and this is sort of derived from that original hospital bed with the springs and all this stuff hanging from it. And you can do a million different exercises. They called it the Cadillac because it was sort of the Cadillac of exercise equipment. I think it was named by a client was the story. So you can do different exercises, some involving hanging, some standing, sitting, kneeling, pushing, pulling, all different kinds of stuff on this one. There are also smaller pieces of equipment. There's the ladder barrel. There's the magic circle. Some of these you can buy commercially as well. This is called the spine corrector. It's a version of the barrel. So what's the rationale for training your core? Everybody talks a lot about core training. We've heard about it tonight that, you need to strengthen your core. You need to get stronger with your core, and that's going to help you do your other sports better. And the idea, the way that I think about it is that if you think about the spine, if you didn't have any muscles attached to it, it's sort of inherently only so stable. You have some basic structures, holding it together in terms of ligaments, but a lot of the real support and stability around your spine is from the muscles attached to it. So I think about it like a baby tree. So if you plant a tree, it's kind of a little wobbly, it's kind of floppy. So we put these wires up. You might see this in your city, locally on your, your neighborhood park, where you have these wires holding the tree up, and that's going to brace it and hold it and keep it from flopping over. And that's what these muscles do. And the idea is that we want these muscles to be engaging both before and in response to what we think of as perturbations, right? So if I throw something and you have to catch it, your deep core muscles, your transverse abdominis, your deep ab muscles are going to activate once you see that thing coming at you, even before you lift your arm to catch it. So you want to get your body ready to do something and then support it while it does that thing. What we know is in people who have low back pain, there's both dysfunction and atrophy of these muscles. So they're smaller and they don't work as well, and they don't fire in advance of the activity. And we know that we can train this. So you can improve that with motor control exercise. We also know that people who have chronic low back pain lose the proprioceptive ability of their lower back structures. So we have these specialized nerves in the joints of the spine that give us proprioception. It tells us where we are in space, and it helps us maintain our postural control. And that gets messed up as well when you have dysfunction in your lower back. So we have a lot of muscles involved in your spine stability. So you have basically the global system, which is sort of, you can kind of think of as everything from your elbows to your knees is sort of involved in where your spine goes. And then you have a lot of local muscles. So multifidi, your psoas, all the stuff that's sort of attached to your spine directly, your quadratus lumborum, and then your abdominals, internal obliques, and then the paraspinal muscles. You have to remember that not only are the muscles important, but the nervous system that controls them, as well as the bones and the ligaments that provide the structure of the spine. So when we think about engaging our abdominal muscles or our core muscles, there's different ways to do it. So we talk a lot about abdominal bracing versus abdominal hollowing. So what are some of the cues that we give people are like pulling your abs, suck in your stomach, tighten up your core. In Pilates, they like to say engage your powerhouse, which is kind of a cute way of describing it. And these have different sensations. Like it feels different to like tighten up your core like you're about to be punched in the stomach versus just like hollowing out your belly and sucking your belly button towards your spine. Breath also plays a role. So when you exhale, if you exhale forcefully, like you're going to cough, that's going to force your abdominals to tighten up. And when you inhale, it sort of, either kind of expands or in some cases sort of sucks in. You can also engage your muscles in different spine positions, right? You might want to engage your abdominals in a neutral spine versus a flexed spine versus an extended spine. And I think some of the issue in terms of injury or sort of injury issues associated with these type of exercises is when you get deep into sort of spine flexion. So if every time you're engaging your abdominals, you're also rounding your spine, that's sort of not the most efficient way to do this. And the textbook injury that I'm going to talk about is what I would like to think of as flexion-based low back pain, which is sort of a spectrum of injuries. And really, it's not an injury per se, but it's more of like a condition that can develop separately from, but be exacerbated by this type of exercise. So Pilates method has a lot of forward bending exercises among neutral and extended ones, but the forward bending ones are often the ones that can cause trouble in someone that has this. So you might have pain that's coming from an irritation in one of your lumbar discs, including a disc bulge or a disc herniation, as well as just what's called an annular fissure, or a little tear within the disc. And this is often pretty clear when you see and examine a patient. It's pretty clear from their history. They have pain when they sit, they have pain when they forward bend or like put their socks and shoes on, and certain activities of daily living, like getting dressed, putting your pants on, getting stuff out of the dishwasher, that sort of thing. In this classic study from like the 70s, the Nachemsen study, this is looking at intradiscal pressure. So we know that disc pressure increases as you bend forward or as you sit compared to the disc pressure, just the hydrostatic pressure of the disc when you're standing. And this was done actually putting pressure probes into people's discs in order to measure these pressure values. Ouch, that probably hurt a lot. So when you look through the literature, you see these two names a lot. There's other ones as well, but Paul Hodges and Stu McGill are two of the names that you see really frequently, and they love to fight and bicker in their articles. Paul Hodges talks a lot about the abdominal drawing in maneuver or abdominal hollowing. Stu McGill is a real big fan of bracing. Each one thinks their own thing is better. But in reality, I think there's a lot of different ways to activate your core, and they're all valid. They all have different uses. So in terms of the deepest abdominal muscle is the transversus abdominis, and it's the one that a lot of people sort of have trouble activating. It's the one that you really activate primarily by performing that abdominal drawing in or hollowing maneuver. So kind of that sucking in the stomach. And so there's a lot of literature that shows that the transversus abdominis is dysfunctional in people who have lower back pain. And Paul Hodges has used EMG, he's used ultrasound to show this, right? We know that you can activate that muscle doing that maneuver, but at the same time, you're also activating it during other types of contractions, such as abdominal bracing. So when you brace your abdominals, you just kind of sort of almost flare your abdominal wall to activate all of your muscles and back extensors isometrically. You're getting a combination of transversus abdominis as well as your obliques. And the idea is that this is providing more stiffness for the spine in a controlled way where you're not solid as a rock. You can still move, but it's stiffening the spine a little bit. This is a colleague of mine from a paper that we wrote where you can see a little bit, if you look very closely, the difference between an abdominal drawing in, where you have this sort of big shadow here, versus an abdominal bracing where you see a little bit less of that. You can also see it in the side view where this is really pulled in relative to the rib cage, but then this is more just sort of isometrically contracted. So we know that there's this association between like spine stiffness for support and stability, as well as like low back pain and ability to do different maneuvers and function. But all of this is really not clear, these relationships. Where we sometimes run into trouble, though, is this idea of the posterior pelvic tilt. And there's something to be said for a pelvic tilt, right? It can be used as an exercise. You want to be able to kind of know where your pelvis is, rock it back and forth. And the problem is that a lot of people associate all abdominal exercises with a posterior pelvic tilt. So every time they go to tighten up their abs, they also kind of tuck their pelvis underneath. There are some studies that show that that causes greater rectus abdominis activation because you're essentially flexing your trunk and your pelvis. But then there's other studies that show the reverse, or that it's kind of similar to the other types of contractions. And so the effect of lumbopelvic flexion rather, on abdominal activation is unclear. However, we really know what it does to the spine, and what it does to the spine is cause increased pressure on those discs, which if you have already lumbar disc pain is not that great. So some of the things we might look at when we see these patients in clinic would be, we'd look at their spine, looking for any atrophy or asymmetry, and we'd want to see their range of motion, both to see how much motion they have, but also if it's uncomfortable or painful, and where they're getting that motion. So when they forward bend, is it a whole lot of hip flexion, or is it a whole lot of spine flexion, or is it what it should be, which is a combination of both of those things. We also do some provocative testing, like a seated slump test. So having someone sit with their back rounded and then extending their knee and dorsiflexing their foot to see if that brings on any back or leg pain. You want to do a full neuro exam, as well as examine their hips and their SI joints to see if they're having lower back pain, where it might be coming from. And then as far as treatment, we want to educate people. We want them to avoid the provocative maneuvers, at least short term. So trying to avoid continuous sitting, making sure to get up, maybe using a standing desk. You know, you don't want to be afraid of bending, but you also don't want to do things that gratuitously cause you a lot of pain. We want to encourage people to do activity as tolerated within the bounds of what they can do without pain. They can do things like running if they can tolerate it, because ideally you're not in a whole lot of forward flexion when you run. You know, if it feels okay, they have my blessing most of the time. We might use certain medications, and then we want to treat them from a physical therapy standpoint more towards a neutral and even an extension-based program if they're having a lot of pain with forward bending. Give them a stabilization program, some functional training, and a home exercise program, of course. In terms of interventional treatments, you might consider things like epidural steroids if they really have a hot flared up disc that's not responding. That would be a really a reasonable thing to consider. From a Pilates standpoint, when we talk about how do we want to progress these people, the beginner system gives you kind of your most stable base of support. So this is someone who's on all fours. This is a very stable situation. This particular exercise does use a flexed spine, but just as an example of something that has a little bit more support. Moving on to the intermediate system is where you incorporate more seated or standing exercises. So a little bit less, less points of support. Then you might sort of balance, on a moving platform. So that's an example of the teaser, which is an intermediate level exercise. So a little bit less supported, a little bit more unstable. You wouldn't want a real beginner to do that. And then finally, the advanced system is the most unsupported, the most technically challenging exercises on the most unstable platform that gets you the advanced system. And when we teach people, we want to instruct them on the technique. We want to progress them so that they can flow from exercise to exercise and actually get a good workout. And then we want to refine the exercises to make them as challenging as we can make them. Teaching in Pilates in the private setting or the sort of group, even a small group setting, is very hands-on. So we use verbal and tactile cueing to help them activate their abdominals properly, as well as their hip muscles. Talk a lot about breath support, and then really watching that lumbopelvic position. So we want them to be in the desired position, whether it's neutral, flexed, or extended, but with support, never collapsing, never sort of flopping into a particular position. This is my mentor, Bob Leekins, who I mentioned before, teaching someone. This is an intermediate level exercise. Actually, it's not an advanced level exercise because you are fairly supported. But here, the legs go out and they go up and overhead, and you really have to work hard to not collapse down into that lower back. So we're working on resisting gravity, basically. And then, of course, the springs of the reformer are helping quite a lot. And so there he is teaching the short spine exercise. And that is about it. I also have a paper on core training in the Pilates method that I wrote with one of our excellent residents, Andrew Joyce. So he's the first author there, which you can check out if you're interested in learning more about Pilates and its relationship to other low back pain types of treatments. And there are my cats again. And just as a side note, I was reviewing this presentation with one of my colleagues earlier today to get her feedback. And we were looking at this last slide. She goes, "Look at this person over here. She's rocking it. Look how great that is." And I felt so good because this is me in about 2003 when we brought the camera into the Pilates studio to take a bunch of pictures of exercises. And I'm still using them because I used to be really good at Pilates. Not as good anymore, but I try.
All right, thanks so much again for your second presentation. So fun to hear about the history of Pilates. Who knew? So now I'd like to invite our attendees to send any questions they have in the chat, and we can open things up for question and answer for our three panelists.
I feel like we've definitely reached everybody's bedtime the week
Yeah, I think it
of
might be a quiet group.
daylight savings and election and all of the things this week. So
All right, well, that is very fair. Before we conclude, would like everyone to know that we do have several more of the textbook injury webinars coming up on November 18th at 8:30 EST. We have Dr. Carrie Kinsky, who's making a presentation on lacrosse, Dr. Margot Putukyan, who's presenting on soccer, Dr. Jeffrey Mans, who will present on rugby, Dr. Allison Brooks on ultimate disc, and Dr. Ryan Lingor on hockey. And then the day after, on November 19th at 9, we'll have a presentation on gymnastics with Dr. Ellen Casey and Dr. Marcia Faustin, who will also present on women's gymnastics. And then Dr. Stephanie Aldrich will present on trampoline. And Dr. Emily Sweeney, who is from CU, will present on her research on spondylolysis. And then our third webinar is on November 21st at 8:30 PST as well. Dr. Lauren Elson will present on dance, Dr. Melanie Hubris will present on breaking, Dr. Pierre Rousier will present on yoga, and Dr. Robert O will make a presentation on CrossFit, HIIT, and high-intensity functional training. So on behalf of everyone in attendance tonight, thank you so much to our speaker panel for outstanding presentations, and would like to wish everyone a nice rest of their evening.